talk about thyroid hormone to go first. We get a ton of questions about this. As a background, the thyroid hormone is an ancillary hormone that has to do with cellular activity in pretty much every system in the body. The thyroid gland itself is a small butterfly-shaped gland on the neck. If you feel it when you swallow, it kind of feels like a slice of deli meat sliding over your windpipe. And depending on the tissue, your thyroid hormone, or T4, is converted to active thyroid hormone, or T3, based upon 3 different enzymes. So you have tissue-dependent levels of thyroid hormone as well.
Yeah, and just to back up and talk about the incidence of thyroid issues, it isn't all that common, but it's also not uncommon. So the number of people that would swing towards either a hyperthyroid state where they're producing too much thyroid hormone versus a hypothyroidism state greatly favors hypothyroidism. Something like in the realm of 5+% of people will have either clinical hypo or subclinical hypothyroidism. And then in terms of hyperthyroidism, that's a smaller piece of the pie. Something like 1 or 2% of people will have hyperthyroidism at some point. So it's not super common. It's not 50% like you might be led to believe by some influencers who want to fix everybody's thyroid, but it's also not uncommon, and it really can affect your health and quality of life.
The theory behind why hypo and actually hyperthyroidism develops is kind of like a spark and fuel theory. So there's all these different antibodies. There's antibodies for Graves, there's antibodies for Hashimoto's, and then 10 to 15% of people with no thyroid pathology and no lymphocytic infiltration, which is classic for Hashimoto's, the most common named hypothyroidism. About 10 to 15% of people with no pathology have elevated levels of these antibodies as well.
Yeah, so basically an antibody is something your body is producing against something that's not really a pathogen, not something that it needs to be attacking. And in the case of like true Hashimoto's, this can lead to lymphocytic infiltration of the thyroid and damage over time, fibrosis, which is replacing the functional thyroid tissue with scar tissue that's not going to be producing thyroid hormone. But as Kyle mentioned, there are a number of people that have these antibodies and they don't actually have thyroid pathology. It's not actually causing damage. So I guess the question is, so what do you do with those people? Let's say somebody comes in, they're like, I was told I have Hashimoto's, I don't want to take medicine, or I don't want to take medicine without getting a second opinion. I have these antibodies, here's my blood work, what do I do?
So there's a spark, but not necessarily a fire. And a lot of times these individuals, rightfully so, look for the cause of this. This is kind of bread and butter functional medicine, if you will. You're looking to address the cause rather than just treat the symptom or throw a medication or a tool at them. And there's a lot of theories behind this. One of the better ones, in my opinion, is that your immune system is like your military, and it runs drills like any good military should. And the drills that it runs is usually against your microbiome, both the good, the bad, and the intermediate microbes in your gut. And then if you look at periods of infection where your immune system is hyperactive, after those sorts of infections, autoimmune diseases can be more commonly onset after that. So I look at the infection or just periods of high inflammatory markers or inflammation as the fuel that kind of ignites that spark, and then it picks up and ends in Hashimoto's. This theory is also true of type 1 diabetes, and it is also true of multiple sclerosis, and it is also true of Crohn's and ulcerative colitis. So that's kind of an overarching theme. We don't need to dive into that super deep, but that is a very common question that patients ask and should continue asking.
Yeah, it's always, there's no dumb questions. If you're asking a question, the odds are somebody else has that question, and if you have a provider that's going to take the time and listen to you, listen to your concerns, and answer your questions, then you found somebody that you can probably have a good working relationship with for a long time. And I think you mentioned recent infections, particular viral infections, can trigger these antibodies sometimes, whether that's autoantibodies like thyroglobulin or thyroid peroxidase antibodies, or whether that's just a positive ANA if somebody's trying to find out if they have an autoimmune condition or not. So looking at that in the context of, well, by now perhaps we've all had a recent viral illness, so it makes the water even further muddied.
Yeah, that's true. That's a good point. Speaking of muddy waters, there's a little bit of a debate on when to initiate thyroid medication, and of course, which medication to initiate as well. But let's chat about some of the pros and cons of early versus late initiation, and also a lot of people ask, well, do I have to do this, and when would I have to?
Yeah, so typically the conversation around initiating medication, like if somebody has a suppressed TSH and your resting heart rate is 180, that's the time to initiate medication would be yesterday. But today is the next best time to get started there. So in hyperthyroid, it's fairly clear. Hypothyroid is what we're talking more about whenever there's a little bit of wiggle room. So if somebody has let's say a single TSH reading that is 5, so by some guidelines, they're subclinically hypothyroid. Some guidelines would say, well, no, if the T4 is normal, then that's normal. You don't need to do anything about it. If the TSH goes above 10, then that's when you can consider initiating therapy. And in truth, most people that have a TSH between 5 and 10, they're not at risk of, they're not at risk of a lot of complications from being hypothyroid. They're not going to be having their metabolism slowed to a crawl. They're not going to develop heart failure from a lack of thyroid. They're not going to go into a myxedema coma from a lack of thyroid hormone at those levels. But it can impact your quality of life. You could have a bit of sluggishness in digestion. You could have a bit of cold intolerance, lower energy levels. So it can impact you. But if I have someone who they have a TSH of 7, maybe it's just a one-off reading, and we say, how do you feel? Are you checking any of these boxes? And they're like, no, never felt better in my life. If I was any healthier, vitamins would be taking me. Well, then I'm not going to initiate treatment. We will, recheck that, because a lot of times you will see an isolated spike once in a while because you're looking at just a snapshot in time.
Yeah.
So somebody may have a TSH of 7, and then you check it a few months later, the TSH is down at a 2.
Of note, biotin supplementation. Biotin, which is a B vitamin, it can raise TSH. It cross-reacts with the assay. So we usually have patients stop their biotin supplement within several days of their thyroid test. And then on a related note, most practitioners have their patients take their thyroid medication after their thyroid test as well, particularly if you take T3 as part of your medication.
I think that, that's an important thing for people to know about, is that if you're taking biotin, it could lead to a false positive and unnecessary further testing or unnecessary medication. But I think the original question was, when to treat. So if somebody, goes in and they have the TSH of 5, it's the first reading, and you have someone who is trigger happy, we'll just use that term for treating somebody with thyroid hormone, then you could have somebody who ends up on a medication unnecessarily. Maybe they do okay with it. Maybe they have some side effects. There's a potential for harm to occur there. If you have someone who is, waiting to treat somebody who is profoundly symptomatic, and there's not another cause of, the fatigue or depression, whatever it may be, until the TSH touches 10, so at 9.9, you're good to go, we'll check it again next year, then you're really just taking the quality of life from that person, and that's the risk there. So you don't want to put everybody on thyroid as soon as you see an abnormal TSH, but you don't want to wait until it's obvious, hypothyroidism that's progressed for several years before you start to initiate medication. And then there's a conversation about which medication do you initiate, because in general there's T4, which is levothyroxine. Thyroxine is mostly what your thyroid produces, about 90 to 95%. There is liothyronine, which is the synthetic T3, which is the active thyroid hormone. So some people are on levothyroxine monotherapy, other people are on liothyronine monotherapy, and then you have people who are on a mixture, whether that's synthetic or whether that's natural desiccated.
And a lot of times before you just empirically put a patient on T3 or Cytomel or desiccated thyroid as well, you want to make sure that they have good sources of iodine, not too much, not too little. Adequate sources of selenium as well. Selenium is the coenzyme or the catalyst for the deiodinase enzyme reaction of T4 to T3 so that your body can make its own T3. Some people talk about T2 and T1, but systemically or medically those are insignificant. They're really only significant in the tissue level or from a scientific standpoint. And another good rule, if you will, is that if the patient is symptomatic and there's an in-between, there's a gray zone of whether or not the objective markers look off, then you start if they're symptomatic. And then you also look at things like a history of AFib or arrhythmia, or even just in an older age group, does this individual have a lot of palpitations? So you're looking for things that would be a red flag for side effects occurring.
Yeah, certainly if somebody, in general, if somebody is older, they're going to be more likely to have side effects from thyroid hormone. There's a more narrow therapeutic window, whereas somebody who's younger, you have more margin for error, as it were. So in terms of the way I look at it, if somebody is symptomatic, a trial of thyroid hormone, whenever there is some gray area, like you said, is reasonable. And then if you see the symptoms resolve, the person's like, oh, this is how I should have been feeling, and your lab work is showing some improvements there that correlate, then congratulations, you successfully treated the patient. If you put them, and they're in the gray zone, you put them on thyroid hormone and they feel worse, they're like, I'm too wound up, I'm anxious, I'm having side effects, or they notice nothing, then there's another cause there that needs to be explored, or you've given them too much medication. So you kind of have to go back and see, okay, what went wrong here, or what are some other things that could be going on that maybe weren't in your first differential.
Another thing to consider when you're starting your thyroid medication is something else off. For example, is SHBG off? Thyroid medication can increase SHBG, which binds androgens and estrogens. Or is your thyroxine binding globulin off? So just like SHBG, there is a binding protein. We can call it TBG to simplify things. And this TBG will bind both T3 and T4. You can look at your ratio of T3 and T4 and free T4, unbound. And you can somewhat estimate it, the binding globulin as well. But when you're on thyroid hormone medication, you can have a good assessment of what this individual's physiology is likely or not likely to do. Desiccated thyroid hormone usually comes in a ratio of, I believe, 4-1, T4 to T3. And then, of course, levothyroxine is 100% T4. Iodothyronine or Cytomel is 100% T3. And your body in general ends up converting a ratio of around 10-1. So those are good things to keep in mind for each individual's regimen.
Yeah, and some people will look at the reverse T3. That's something that we will look at, and it doesn't always correlate with the clinical picture. So it's important to not just get caught up in the numbers and too much of an algorithmic medicine, but looking at the patient in front of you. But for some people, levothyroxine, just plain old Synthroid, works very well, and they're well managed on that. For some people, and I think we've both seen some examples of this, where you give somebody, or somebody comes to you on levothyroxine and you see a relatively low level of free T3, free liothyronine, and then you see a quite high level of reverse T3. And sometimes this could be due to inflammatory state or metabolic dysfunction, where it's just getting shuttled down the wrong pathway. So fixing that, getting them to optimal health, more than likely is going to help them convert appropriately. But there is a subset of patients, and again, I would say it's a rather small subset that does do better with a combination of T4 and T3.
Absolutely.
And there's a couple small populations and some studies that people like to point to. Well, people lose more weight on the T4, T3, and if you have somebody who is hypothyroid, struggling with weight, then maybe that makes sense to have a mixture. But if you have somebody, because you can have people that are quite thin that also have hypothyroid, then giving them something that's associated with weight loss may not make the most sense.